Okay, I think then we're ready to start. It's 3 o'clock. Thank you for everyone who's joining us today as part of the Global Public Health Week. We're very excited. Me being Sarah Mandville, along with my colleagues Natalia Messali and Anna Romanova. We three are at the University of Lucerne, but we're also part of the Swiss Learning Health System. And today we're going to introduce to you a great project on co-creating a health equity training for researchers in the field of public health, health sciences, health services research. And we're actually taking a look from a learning health systems perspective on it. What are you going to hear about today? First of all, for those who are not familiar, I would like to introduce you to what we mean when we talk about the learning health system. And then I would like to introduce you to the Swiss learning health system, a way where we attempt to basically leverage something that has been initially used more in a clinical setting, so to say. And then my colleagues, Anna and Natalie, are going to take over and present to you the actual project, Co-Creating Health Equity Training within the Swiss Learning Health System. So what is actually a learning health system? Some of you might be familiar with it, some might be less so. So we take the opportunity to briefly introduce you to this concept. The concept has been introduced already around 2005, 2007 by the Institute of Medicine in the United States. And about 2 years ago, also the World Health Organization, so not at all 20 years, but maybe 15 years later. And they published a flagship report on learning health system pathways to progress, where on the one hand side, they give a great overview for all of those of you who are interested on what we actually mean when we talk about learning health systems, try to provide conceptualization, but they also provide a large variety of different case studies and projects where across different countries that have tried to integrate learning health systems at sometimes public health and policy level. So it's worth taking a look at this. In its essence, learning health systems are actually pretty straightforward. We, often researchers, we generate data, we learn from the data, so we generate knowledge based on the data. This knowledge is implemented hopefully in an ideal case, but what we often see is that not, or very minimal research actually makes it into practice. But in an ideal world, we're putting knowledge into practice, we generate new data from practice, from performance data, create new knowledge, and bring it back into practice. Why are learning health systems so interesting? As said, it's not that difficult to conceptualize, think about it. And it has been often used, especially in the field of health in the clinical setting. But in the last years, we see countries or initiatives, not even countries, initiatives mostly, trying to apply learning health systems at a policy level, at a public health level. Learning health systems are particularly interesting because they can try to address so-called wicked or fuzzy problems. What do we mean by wicked or fuzzy problems? These are problems that often are very hard to define, and it's not easy to resolve them in a very traditional, straightforward way. As in the case of health equity, for example, they may involve many interdependencies, many stakeholders. They are often multi-causal and socially very complex. Examples are, for example, as I said, health equity issues, but also rising healthcare costs or a growing digital divide. What makes learning health systems interesting is that we have to think about the data sources that we're using. We're sort of departing from the initial use of this data that we're interested to use them for. So initially we thought, oh, we're going to use this data for research, for quality improvement. But actually they're a great source for learning health systems. By using data that is available, we try to inform, as I said, practice. We try to generate feedback, and we try to re-inform practice. So we're trying to create these continuously and hopefully, at a certain point, rapidly operating cycles. I'm quoting Friedman here, who is the head of learning health systems at the University of Michigan, one of its kind worldwide, I would say, at the medical school. And he says learning health systems improve individual and population health by marrying discovery to implementation. And that again sounds a bit one way because we're again also learning from implementation. We're learning for discovery, so to say. So what does this mean at a policy level? I mean, I think we can all imagine how this might work in the clinical setting where we try to, for example, try to improve treatment for patients. Because based on patient data, we learn how a treatment works. We can see, we can see how we could improve it. We could try to implement this into practice. But what does this mean at a higher national or policy level, for example? When we think about learning health systems, what we try to implement are so-called learning communities. And learning communities bring together stakeholders from science, policy, and practice. And they learn from each other within the cycle via dialogue, ongoing dialogue. That's the most important part, ongoing dialogues. So in its essence, learning health systems and the idea to implement it at a higher non-clinical setting is very much about knowledge translation. What we try to do is we try to move evidence through these learning cycles into policy, into practice, by disseminating this knowledge, by applying this knowledge, and hopefully learning again from the application of this knowledge. So to make it a bit more concrete now, all of this is rather abstract. I want to give you an example how we are trying to implement this. So the Swiss Learning Health System is, as I mentioned, an initiative that me, along with my two colleagues here, are part of. And before I dive into the Swiss Learning Health System, some of you might not be as familiar maybe with Switzerland as we are, of course. So a little bit of background. Switzerland is a relatively small country compared to a lot of other countries. It has only 8.7 million people living in Switzerland. It's predominantly urban. However, we also have some remote mountain areas. It's highly decentralized healthcare system. We have 26 cantons, and each canton is independently responsible for funding or monitoring or promoting healthcare, for example. So even though it's very small, it's very, very decentralized. Despite this, life expectancy is one of the highest in the world. And yet, as many countries around the world, Switzerland is facing its challenges, whether it's rising healthcare costs, rising chronic condition, or rising aging. So also we have to deal with complex or fuzzy or wicked problems, as I initially said. So who are we in the Swiss Learning Health System? We started in 2017 as a national initiative, mainly bringing together health systems and health services researchers with the aim to bridge the gap between research, policy, and practice. If you remember, I talked about the learning communities, so bringing these three groups together. And our aim is really to bring all the stakeholders in the Swiss health system together, whether it being providers, insurers, patients, or policymakers or decision makers, to develop and engage and enable continuous integration of evidence-informed solutions or recommendations, and to, of course, discuss those recommendations. Overall, we are 11 universities and universities of applied science in this initiative. We have a health system advisory board that provides overarching feedback to our project. It steers us in a way on the topics that we should address within the learning health system. And the board brings together high-level people from policy and practice. We have a governing board with 33 senior academic professionals, and we have a current cohort of 33 doctoral researchers. This is already the second cohort that is with us, and we also have international partners involved in our project. So what does the learning cycle look like in the Swiss Learning Health System? We ideally, and we have gotten much better with time in this, we try to identify challenges and pressing issues in the healthcare system or in the health system in Switzerland. And we do that through the collaboration of our network, the Health System Advisory Board that provide feedback, that give us insights on what's coming up on the horizon, so to say, and topics we should deal with. Based on this, we develop evidence briefs that are narrowed down, so to say, to policy briefs. These are, of course, standalone products, but in our case, they often serve as an input for stakeholder dialogues. Initially, stakeholder dialogues, we came really much, or very much from a perspective of policy dialogues. So policymakers engaging in structured dialogues about an issue or a challenge, and this was healthcare system, that was based on the policy brief, the discussion. However, as Anna and Natalie are going to highlight, we have moved a bit away from that. Because we wanted to increase, and I think that's very important if we talk about learning communities, we really wanted to increase buy-in and ownership among stakeholders that are involved. So we have moved a bit more towards concepts such as co-creation in forms of workshops, but also, so to say, extended dialogues, because only when partners are co-creating, they also can have ownership of the final product. In an ideal case, and I want to say a word of caution here, we monitor and evaluate what happens after the dialogue. I want to be cautious here because we are addressing challenges that we do not expect to see changes within the next couple of months. This may take years. However, what we try to do is, because we're supporting knowledge translation, we try to monitor and evaluate whether outcomes of the dialogue, whether contents of the dialogues or the policy briefs are shared, are disseminated, are further discussed, and we look how the results of dialogue could inform our learning cycle to potentially continue learning cycles. What have we done so far? Since 2017, we have published over 26 policy briefs and conducted stakeholder dialogues that brought together over 90 stakeholders from policy, practice, and research. And there are many more to come. This year, we have planned a couple of more. We have trained over 50 doctoral researchers in learning health systems in knowledge translation activities. And without further ado, I also would like now to hand over to my colleague Anna, who's going to introduce you to the doctoral program of the Swiss Learning Health System, to give you a bit more of background what follows next.
Thank you, Sarah. So as Sarah said, it is really important for a learning health system to establish a learning community. And this is why we provide a lot of capacity building activities that I'm happy also to participate in. Our goal with our capacity building activities is to establish a community of researchers who understand the importance of collaboration of all actors in the health system. So we highlight this topic of collaboration and knowledge translation from various angles by offering different courses and events. We conduct also conferences for our doctoral students. We conduct doctoral retreats and journal clubs. Now we also extended our reach to offering online webinars. Last semester, we offered colloquium series on synthesizing science pathways to impact. And this semester, we are offering webinar series on science communication. And to highlight what aspects do we explore in our doctoral course program, I will introduce these slides. So our PhD students are expected to develop a policy brief and conduct a stakeholder dialogue. And we increase their capacity by providing training in the 5 core areas. Those are the design and vision of a learning health system, health systems and services, evidence-informed policy framework, implementation science, and also communication in a learning health system. If you're interested in our events and capacity building activities, please visit our website, follow us on LinkedIn, and subscribe to our YouTube channel. We'll have a newsletter that you can subscribe to. We regularly post webinar announcements and event announcements, and we will be happy to see you there. So one additional aspect that we are highlighting in this webinar is co-creation. In our journey to establish a learning health system, our project is committed to stakeholder engagement and collaboration at all stages of research. As Sarah said, from issue identification, prioritization to results dissemination. This interaction across the research cycle is crucial for effective knowledge transfer and the research uptake in practice. And this is why central to our strategy now is the concept of co-creation. Co-creation is not a complicated concept to understand too. In its essence, it's about collaboration between various stakeholders at all stages of the project to creatively solve a shared challenge or a problem. So apart from being very important for stakeholder engagement, co-creation is really now considered a suitable approach to address complex social issues, which I often refer to as wicked problems. And wicked problems, as Sarah mentioned, are a central point in learning health system science. Co-creation brings numerous benefits to the stakeholder engagement process in the learning health systems. This involves the stakeholder engagement and their voices being heard throughout the whole research process. Also, the solutions that are being co-created are being drawn on collective creativity and collective expertise of the co-creation participants. And in the end, this brings us to the point that the co-created solutions are more innovative than those that are emerging in a more hierarchical or traditional approach than co-creation. Then, to underscore the transformative potential of collaborative efforts for a learning health system, Natalie Messerly will introduce her approach to use co-creation in practice for one of her research projects.
Awesome. Thank you so much, Anna. Hi again, everyone. As Anna mentioned, we're really going to shift and discuss a current Swiss Learning Health System project that focuses on co-creating health equity training. So this project aims to extend the existing competency domains within the Swiss Learning Health System program to specifically focus on addressing health disparities within the Swiss context. We can also kind of ask, okay, well, why is this important? What is the real motivation? And I can explain to you that this really came as a lessons learned from a previous project that took place in the Swiss Learning Health System, where we had alumni of the program talking about how they're in policy, clinical settings, and they really need to answer and address questions that focus on health equity. And they realized that the design of their research or the approaches that they were taking is not producing the data that they need to answer these really complex and interrelated challenges that need answers to, that are relevant, and maybe even there's a political issue that's on the table. And so that's one reason why we said, maybe we should consider this. And then also there's a recent call that took place out of the French-speaking region of Switzerland, where they were calling to incorporate more equity-based training in post and pre-graduate course offerings in Switzerland. In addition to this, there's also been a lot of national movement. So there's been the recently created Swiss Health Network for Equity, which previously, they were a network of hospitals that really focused on integration and migration, and it's evolved over the years to address other areas and other groups that have been marginalized by the Swiss health system. In addition, the Federal Office of Public Health, they are hosting a health equity forum. This year would be the third year of the health equity forum, bringing together people in policy practice, as well as academia together to discuss relevant health equity challenges and opportunities within Switzerland. And then recently published was the Swiss Health Observatory's report on health equity. And this report emphasized the need for more research. Now, taking a look at the project components, and maybe also asking, why are we even taking a co-creation approach? And maybe I'll just even back it up. Co-creation is not a new concept when it comes to developing curriculum. So there's documented cases of co-creation approaches dating back to the early 1900s. And then there was another wave that took place in the 60s. And I think co-creation at this point, as Anna mentioned, it's being used across different industries. And now really the focus is also being included in the public health sphere. And so this is one reason why we decided to take this approach, as both Anna and Sarah mentioned, that the challenges that researchers, that people in policy and practice are facing really cannot be solved by just a basic linear approach. So when we talk about co-creation of the curriculum, this involves co-designing of a curriculum, a program, a course, usually before the program, course, curriculum takes place. And this one often involves only a selected group of students. There is a co-creation in the curriculum approach, and this involves all of the students. And as Sarah and Anna also mentioned, we are in the second phase of the doctoral cohort, and most of the doctoral researchers are all wrapping up their PhD thesis. So we are really lucky and gracious that even a good selected amount of researchers, a part of this cohort, are able to participate. And unfortunately, we couldn't get the entire cohort. So the aim of this project is really to meaningfully engage stakeholders, again, from education, research, policy, practice, as well as patients, to contextualize an existing health equity domain and learning competency. And so when I say existing, Sarah mentioned that this concept originated in the US. And along with this concept is a framework for training. And this includes several domains. And in 2022, and due to similar reasons that are actually happening within Switzerland, the US added the health equity domain. The domain actually is health and healthcare equity and justice. And what we're focusing on is really contextualizing what they've created to meet the needs of the Swiss health system. The second objective is to develop a course and its curriculum, so really focusing on the learning materials, assessment strategy, the contextual and thematic priorities that should be set. And then the third aim is to explore extending this traditional approach of co-creation. As mentioned here in the definition, it's really students and staff. And our approach it has a little bit of novelty to it because we are including people who are actually going to be impacted by the efforts of the scientists who will be trained after they finish their training. So it's a really this is where kind of the innovation really lies, because the people who are producing the evidence are getting trained, and they're creating this curriculum with people who will ultimately end up using it for decision making. Here is the project timeline for just a quick overview. We had a kickoff meeting in February, and the past few months have been our preparatory phase, where we focused on contextualizing the previously developed framework. And May and June will be the curriculum development workshops, the co-creation workshops. July and August, we will summarize, evaluate the workshops, and really finish the module planning so that can be operationalized. And then this fall, we will implement the model and we will also evaluate it. And then the first half of next year is going to be dedicated to reporting. So when I mentioned the preparatory phase, this included academic experts from Swiss Health Disparities Research, community-based participatory research, and community-engaged health services research, as well as experts in co-creation and integrated knowledge translation approaches. Experts were from every single language region, as well as every single national language was represented in our core group. In addition to that, we were really lucky to also collaborate with learning health system science experts in the US who have a specific specialization in health equity. And when we use the term health equity during our planning phase, it was really exciting because everyone has these different definitions and that they always go back to, and that's really relevant for them and maybe their thematic professional focus. But as a core group, we were all able to kind of go back to this image. And what you're seeing is an adapted image from Shel Silverstein's The Giving Tree. And what it explores is the inequality and equality, and it extends it to equity and justice. And what the core group agreed on is that we really want to focus on this final section where we train scientists into focusing on addressing system level challenges or opportunities that offer not only equal access opportunities to health, but also the tools necessary. In addition to this, we worked very closely with a self-assessment competency that was created by the group at Northwestern. They developed a self-assessment competency for learning health system science. So in addition to the domains that was created by the Agency of Healthcare Research and Quality, this framework further drilled down and talked about what proficiency and the different level of skills could be considered or explored for each domain and competency. So what you're looking at right now is the provisionally contextualized Swiss Learning Health System core area for health equity, as well as the learning competencies. And I just want to emphasize that this is provisional because what we're actually going to be doing, as mentioned earlier in the project timeline, is we're going to be further contextualizing these competencies to make sure that all of the considerations that we can reach consensus on are included, and that the whole co-creation team is able to be behind this framework when it comes to developing the content, the themes, and the delivery of the course. So when we talk about the co-creation workshop and co-creators, what you're looking at is our stakeholder mapping exercise. And one thing that's really important is that we have representation, not only language and gender diversity, but also when we talk about the role and focus level of the participants. So when we talk about education and research, it's really important that we have Swiss Learning Health System PhDs, but also other PhDs that are working in health sciences and public health, postdocs, professors, and also curriculum coordinators. And when we talk about policy, we also want to consider those working at the cantonal and federal levels. This could be decision makers, program managers, but also we're including people who work for knowledge translation platforms and knowledge brokers. So these evidence support systems, the people who they may not be the producers of primary research, but they work on synthesizing evidence, whether it's for advocacy, whether it's answering direct research questions for commissions. We also want to include them because of their perspective and at the intersection that they work at. When looking at practice, this is also another area that we really need diversity of participation. So we're including service providers to actually maybe national representation of a professional society or advocacy group or maybe a public health organization that works at the varying different levels. And this is not only for health, but this is also for social services. And then for the patient population, we are including patients themselves, but also patient representatives or program managers that represent specific patient population groups. And the patient population groups that we decided to focus on were the patient population groups that were identified by the Swiss Health Observatory's Health Equity Report. So we really want to focus on including representation or individuals that are that could be migrants or refugees that are a part of the queer community, those that may be in rural or remote settings, persons who have mental health needs, individuals who may have lower income, or those who may be undocumented. So now kind of the meat and potatoes of the presentation. What are our workshops going to look like? So we just finished contextualizing the core area and learning competencies. We're in full swing of recruitment, and thankfully it's been really positive. And in May, we are going to have our first workshop. But before we have our first workshop, we have a whole list of preparatory materials. So the workshop agenda, we're also going to provide an introduction video just of the concept of co-creation, what the workshops will look like, what resources is available to them so that they feel like they're able to meaningfully engage during the workshop. We'll also include Learning Health System and Swiss Learning Health System overview slides, so they don't have to start from zero or feel like they have to do their own desk research. We'll also have a scope and purpose document just to ensure that everyone is on the same page with the exact objectives that we have. And then we will also have a glossary. And I don't know, this looks like there's a spelling error. I don't know if it's French or German glossary, but we will have a glossary that has all of the words that we'll be using for the workshops. And when we talk about the consensus approach, we'll be using a modified Delphi approach, and the surveys will be distributed 1 month before each workshop. So each participant, each co-creator will share their thoughts, provide their feedback in a survey format. And all of this will be summarized and presented in each workshop. And when we talk about consensus, we're going to be using a 75% agreement threshold. And this is what we're going to be considering consensus among co-creators. So for the first workshop, we have the preparatory materials, but again, we're going to really focus on setting the context for the first workshop. We're going to review the survey results together. We're going to confirm existing consensus, and then we're going to highlight areas that also just need to be considered again. We're going to incorporate new ideas and suggestions, and all of this will be added to the next survey. For the second workshop in June, we're going to review the second round survey results and hopefully reach and confirm consensus of outstanding items if possible, and reach a final decision on what the curriculum should look like, its delivery methods, learning materials, and so forth. So this is where we're at in the project. And here are some references from some of the sources and images that you've seen today. And I just want to thank you all for listening, and thank Anna and Sarah for also presenting with me. And we can open the floor if there are any questions.